Your PSA just came back elevated, and the first thing that probably crossed your mind was, is it cancer? It's a natural reaction. That one number, PSA, has become almost synonymous with prostate cancer in the minds of many. But here's the thing. An elevated PSA doesn't necessarily mean you have cancer. In fact, in most cases, it doesn't. See, PSA is a protein produced by the prostate. It's useful, yes. It can help detect potential issues, but it's not specific to cancer, inflammation, a simple infection, benign prostatic enlargement. Even recent exercise or sexual activity can cause your PSA to go up. And yet, too often, men are rushed into further testing, sometimes even treatment, based on that number alone. That's where problems begin, because when PSA is taken out of context, it can lead to overdiagnosis, unnecessary biopsies, and treatments that may never have been needed, treatments that can affect quality of life in very real ways. So in this video, we're going to slow things down. We'll look at what PSA actually tells us and what it doesn't. We'll talk about why a high PSA might be harmless and when it might not be. We'll also explore the role of testosterone, a key player that's often overlooked, and how metabolic health, like diabetes or high blood pressure, can influence cancer risk in surprising ways. We'll look at the newer tools we now have, like prostate MRI, and how they've changed the way we assess and manage prostate cancer risk today. And by the end, my goal is simple: to help you understand your PSA results in context, calmly, clearly, and based on the best medical evidence we have. If you find this kind of deep, honest health content useful, I invite you to subscribe to the channel, leave a comment if you have questions, and share this video with someone who might need to hear it. Let's get started. What is PSA and why can it be elevated without cancer? Let's start with the basics. PSA, Prostate-Specific Antigen, is a protein made by cells in the prostate. Its primary biological role is to help keep semen in a liquid state, but a small amount of PSA naturally leaks into the bloodstream. And that's what we measure during a PSA blood test. Now here's what many people don't realize. PSA is not a cancer marker, it's a prostate marker. In other words, PSA levels can rise for many reasons that have nothing to do with cancer. For instance, if you have a prostate infection, something called prostatitis, your PSA can shoot up dramatically, even if there's no malignancy at all. An enlarged prostate, or benign prostatic hyperplasia, which is extremely common as men age, can also lead to a higher PSA. And then, there are factors that have nothing to do with disease: recent ejaculation, prolonged cycling, a digital rectal exam, even a urinary tract infection. All of these can cause temporary PSA elevation. And let's not forget age. As men get older, the prostate tends to grow. A PSA of 4.0 might be considered normal in a 70-year-old, but concerning in a man of 45. So, what does this mean in practical terms? It means that PSA is a sensitive test, but not a specific one. It can detect changes in the prostate, but it cannot tell us why those changes are happening, and this is where problems begin. Because when an elevated PSA is interpreted in isolation, without looking at context, without asking the right questions, it can set off a chain reaction of anxiety and unnecessary procedures. In many cases, men are referred for biopsies after a single elevated PSA test, even though the cause might be entirely benign and self-limited. And for some, that leads to treatment, surgery, radiation, hormone therapy, for a cancer that may never have caused symptoms, never spread, and never threatened their life. That's why understanding the limitations of PSA and the many benign reasons it can be elevated is absolutely essential. This isn't about ignoring PSA, it's about respecting its complexity. So now that we understand PSA can be elevated for many non-cancerous reasons, let's talk about what happens when that nuance gets ignored. Because unfortunately, it often does. Here's the typical scenario. A man gets a routine blood test. His PSA is higher than the lab's normal range, say 5.6. Without further context, the immediate response might be, "We need to investigate this. It could be cancer." From there, the next steps often follow a familiar path, a referral to a urologist, a prostate biopsy, and if the biopsy shows something, even a small, slow-growing lesion, then a treatment discussion begins. Now let's be clear, sometimes that's absolutely necessary. Early detection can save lives, especially for aggressive forms of prostate cancer. But here's the problem. Not all prostate cancers are dangerous. In fact, a large percentage of them grow so slowly that they would never become life-threatening, even if left untreated. This is what we call overdiagnosis, identifying a condition that meets the pathological definition of cancer, but that would never cause symptoms or death in that person's lifetime. And once a diagnosis is made, especially one with the word cancer attached to it, it's very difficult, emotionally, and sometimes medically, to not treat it. That leads to overtreatment, surgery, radiation, hormone therapies, all of which carry significant risks, like incontinence, erectile dysfunction, or long-term metabolic effects. All for a cancer that may have posed little or no threat. This is not theoretical. Over the past 2 decades, countless men have undergone treatment for low-risk prostate cancers that might never have progressed, and many live with the consequences of that treatment every day. So, what's driving this? Often, it's the misinterpretation of PSA as a direct indicator of cancer, and the assumption that every detected cancer must be treated immediately. But medicine is moving forward. We're beginning to recognize that not all elevations require a biopsy, and not all cancers require treatment. Active surveillance, modern imaging, better risk stratification. All of these are changing the way we approach these decisions. But the first step, and it's a crucial one, is understanding that PSA alone is not the enemy, and higher doesn't always mean worse. It's context that matters. When we talk about prostate cancer, or any cancer really, it's easy to get tunnel vision. We see a high PSA, we hear the word cancer, and suddenly, nothing else seems to matter. But in real medicine, and in real life, we have to think bigger. Because for most men over 50, prostate cancer isn't the only risk on the table. Heart disease, stroke, diabetes, Alzheimer's. These are not abstract threats. They're statistically far more likely to impact long-term health and survival than early-stage prostate cancer. So here's the question. Are we focusing all our attention on the prostate and ignoring the bigger picture? And when a treatment decision is on the table, especially for a cancer that might not be aggressive, we have to ask, what's the cost of that treatment? Prostate surgery can be effective, but it's not without risks. Urinary incontinence, sexual dysfunction, chronic pelvic pain, radiation. It can lead to bowel and bladder issues, and hormonal therapy, which lowers testosterone, can increase the risk of osteoporosis, fatigue, mood disorders, even cardiovascular problems. So we have to ask again, are we trading one risk for another? This doesn't mean we shouldn't treat cancer when it's needed, not at all, but it does mean we should treat the right cancer in the right patient at the right time and with full awareness of the trade-offs. And here's another perspective that's often overlooked. Many men diagnosed with low-risk prostate cancer, the kind that might never spread, actually live just as long without treatment. There are studies showing that survival in these men, even without any immediate intervention, can be nearly 100% at 5 years, sometimes 10 or more. That's not a reason to ignore it, but it is a reason to pause, take a breath, and consider a more nuanced approach to weigh the cancer risk against the treatment risk, and to make a decision not based on fear, but on balance. Because real prevention and real health is about more than one lab result. Now here's a piece of the puzzle that often gets ignored, sometimes even by physicians: testosterone. For years, testosterone was blamed as a kind of fuel for prostate cancer. The idea was simple: more testosterone equals more cancer growth. That belief led to decades of aggressive hormone-blocking treatments and a general fear of testosterone replacement in men. But today, the science tells a different story. Yes, testosterone can stimulate prostate tissue, and yes, it can influence PSA levels. But testosterone is not the cause of prostate cancer. If it were, then younger men, who naturally have higher testosterone, would be the ones getting prostate cancer. But they're not. In reality, prostate cancer is most common in older men, at the exact time in life when testosterone levels are naturally declining. Testosterone. And that brings us to a critical insight. Low testosterone doesn't protect against prostate cancer. In fact, it may be linked to more aggressive forms of the disease. Let me explain. When testosterone levels are very low, the body's hormonal environment becomes imbalanced. This can affect not only the immune system and metabolic health, but also the behavior of prostate cells. Some studies suggest that low testosterone may be associated with higher-grade, more aggressive cancers, the kind we should worry about. So when interpreting a PSA result, the testosterone level matters. Here's why. A high PSA, in the context of normal or high testosterone, might simply reflect benign prostate activity, like an enlarged gland or mild inflammation. But a high PSA with low testosterone is more concerning. That AS when we have to look more closely, possibly with imaging or biopsy, because something isn't behaving as expected. It's like this: testosterone is the fuel, yes, but fuel alone doesn't start a fire. There has to be a spark, a structure, a context. And when testosterone is low, the system is already under stress. That stress may actually create conditions that favor cancer development, especially in the presence of chronic inflammation or poor metabolic health. So once again, context is everything. A PSA value on its own tells you very little. But a PSA value interpreted alongside testosterone levels, age, symptoms, personal health history, that tells you a lot. And it can mean the difference between watchful waiting and missing something important. So far, we've talked about how low testosterone might be a signal for more aggressive prostate cancer, but that's just one part of a much larger pattern, one that involves metabolic health. And this is where everything begins to connect. Men with low testosterone are much more likely to suffer from a group of conditions we call cardiometabolic diseases. Things like type 2 diabetes, hypertension, obesity, high cholesterol, insulin resistance. These aren't just isolated problems. Together, they form a systemic imbalance, one that affects hormones, immune function, inflammation, and even cancer biology. Now, here's where it gets really important. Men with metabolic syndrome are not only more likely to have lower testosterone, they're also more likely to develop more aggressive forms of prostate cancer. This isn't a coincidence. Chronic inflammation, driven by insulin resistance and visceral fat, creates a microenvironment where cancer cells are more likely to grow, escape immune detection, and spread. And when testosterone levels are low, this inflammatory pattern worsens. In other words, metabolic dysfunction and hormonal imbalance often go hand in hand, and together they can influence both the development and the aggressiveness of prostate cancer. This also helps explain why some men, even with normal or low PSA levels, may still harbor high-grade, dangerous cancers, because their metabolic and hormonal environment is working against them quietly. So, what does this mean in practical terms? It means that when we look at prostate health, we cannot separate it from the rest of the body. A man with low testosterone, central obesity, insulin resistance, and high blood pressure isn't just at risk for a heart attack. He's also more likely to have worse cancer outcomes if prostate cancer is diagnosed. And here's something that often gets overlooked: improving metabolic health through diet, exercise, weight loss, and sometimes testosterone replacement, when medically appropriate, may not only improve general well-being, but also lower inflammation and potentially reduce cancer risk or progression. No, it's not a guarantee, but it's a pattern we see again and again in the literature. Better metabolic health often goes hand in hand with better cancer outcomes. So instead of treating the prostate like it exists in isolation, we have to step back and see the man as a whole, because prostate cancer doesn't happen in a vacuum. It happens in a hormonal, metabolic, and inflammatory context. And that context matters for prevention, for diagnosis, and for treatment. We've spent a lot of time talking about what PSA can and can-T tell us. Now, let's shift to something that has changed the game in prostate cancer screening: multiparametric MRI of the prostate. For decades, the diagnostic approach was relatively straightforward, but limited. PSA goes up, you get a digital rectal exam. If anything seems off, you get a biopsy. But that path had a big flaw. It often led to blind biopsies, meaning samples were taken at random from different areas of the prostate, hoping to find something, or hoping not to miss something. But blind biopsies come with risk. They can miss aggressive cancers, or worse, they can detect tiny, clinically insignificant lesions, leading to overdiagnosis and overtreatment. This is where MRI has changed everything. A modern prostate MRI doesn't just show the shape of the gland. It provides detailed imaging of tissue architecture, vascularity, even cellular activity. It allows radiologists to spot areas that look suspicious, places where the structure or blood flow is abnormal, and target those areas for biopsy if needed. In many cases, if the MRI is clean, if it shows no suspicious lesions, the risk of finding a clinically significant cancer is very low. So instead of immediately rushing to biopsy, a man with an elevated PSA and a normal MRI might safely avoid invasive procedures altogether. And if a lesion is found, MRI allows for a targeted biopsy. That improves diagnostic accuracy and reduces unnecessary sampling. But MRI does more than that. It also helps guide active surveillance strategies for men who've been diagnosed with low-risk prostate cancer and want to avoid immediate treatment. Regular MRIs can help monitor for changes over time, making sure the cancer isn't progressing. In short, MRI has brought a level of precision and personalization to prostate cancer screening that PSA alone could never offer. And here's the most important point. MRI allows us to move away from fear-based decision-making toward evidence-based, risk-adapted care. It helps avoid unnecessary biopsies. It reduces overtreatment, and it gives both doctors and patients a clearer view of what's actually happening or not happening inside the prostate. So, if you or someone you know is facing an elevated PSA, it's worth asking, has an MRI been done? Because in today's world, it should be more than just an option. It should be part of the standard conversation. So let's step back for a moment. We began with a common fear. A high PSA must mean cancer. But as you've seen, the reality is far more nuanced. PSA is not a diagnosis, it's a signal, and a signal that must be interpreted in context. That context includes infections, inflammation, or benign prostate growth, your age, your testosterone level, and your overall metabolic health, the presence or absence of symptoms, and most importantly, the use of modern tools like MRI, which allow for smarter, more targeted decisions. We've also seen that low testosterone and poor metabolic health may not protect you. In fact, they might increase your risk of more aggressive disease, and that the biggest threat isn't always the cancer itself. It's the way we react to it without the full picture. Overdiagnosis, overtreatment, and the real human cost that comes with both. So, if there's one message to take away from this video, it's this. Don't let a number define your future. Ask questions, seek second opinions, use modern imaging, and most of all, understand your body in the full context of your health. Because prostate cancer is real, but so is unnecessary harm. And the best medicine, as always, is thoughtful, individualized care. If you found this content helpful, I invite you to subscribe to the channel. Leave a comment if you have questions, and share this with someone who might benefit from a clearer perspective. And in the next video, we'll go even deeper, exploring how lifestyle, exercise, and even nutrition may influence prostate cancer risk, progression, and recovery. Thank you for watching, and take care of your health wisely.